For our next panel of speakers here, we're going to be having a panel discussion on quality blood cultures and how that begins at collection, okay? The four panelists today are Heather Alvarez, lab manager at Prairie Ridge, Columbus. We have not seen her yet today, so this will be exciting. We have Megan Selle. Is it Megan Selle or Megan Selle? Selle, the microbiology lab supervisor at ThedaCare in Neenah. We have Jessica DeJong, lab manager of support services with specialty in phlebotomy from Wausau, Aspirus. And Dan Lockwood, as the facilitator of the talk today, as the manager of micro and molecular diagnostics, Wausau, Aspirus as well. Okay? So I'm going to hand it over to them. I'll be running around a microphone, and if we also have another microphone here, so make sure that you wait for you to ask questions until you get the mic for all recording purposes. Ideally, say your name and your institution as well. Thank you.
Okay, thanks everyone for the opportunity to walk through our contamination reduction project. I apologize, my voice is a little gravelly today, and I'll do my best to make it through. Before I get started, I want to just thank some important groups within the Aspirus organization. So the collectors, phlebotomists and nurse collectors, and our great laboratorians that are doing this work every day. So the format will be, I'll walk you through some highlights from our project over the last 5 years, mix in some questions for the audience to really help us understand understanding from the audience level, and then I'll turn over discussions to the panel of experts at the table. So a lot of topics to talk about in reduction of contamination, site selection, site prep and antisepsis, bottle antisepsis, inoculation techniques, and what we're going to spend the majority of our project talking about is the diversion devices. So we're going to start off with the audience poll right away. In your institutions, who performs blood culture collections? All right. Okay, so we had a good mix here. Looks like predominantly lab plus ED and nursing staff. Only about 20%, 18% are a lab-only collection, and a little bit of other mix beyond that. Thank you for that. Red box, okay, thank you. Appreciate it. Okay, looks like most of you are involving nursing for your collections. So what percentage of the blood cultures collected in your institution are collected by nursing staff? Okay, looks like, again, predominantly the 25 to 50% are collected by nursing staff, so we could confidently say nurse collectors are a very important group in your overall success. So I'll turn it over to the panel for a moment to talk about, in more depth, the collection groups that you work with most closely and why they're so important in your overall success.
So at Aspirus, our phlebotomy team probably does about 75% of our collections. ED probably does about 20, and then the inpatient nursing probably does the rest. When I talk about inpatient nursing, they're mostly drawing off of a central line or in our NICU, because our lab team does not draw the babies in the NICU, so the nursing staff are drawing all those blood cultures. So for the majority, it is our phlebotomy group that is doing all of our blood collections for cultures.
At ThedaCare, we have a pretty similar situation in our bigger regional hospitals. It's about 50-50, where we have ED nurses collecting blood cultures versus lab staff. Just started introducing floor staff in the ICU for collecting blood cultures off of lines. And then in our critical access hospitals, it shifts more to a lab collection versus ED nurse collect.
We are pretty much exactly the same, but we have no NICU, so my nurse collections are pretty much ED only.
Okay. So I'll introduce the diversion device, our initial specimen diversion device. These are small inline devices that are really a reservoir to capture the first few mils of blood or less. The main focus is to capture the skin plug from the venipuncture itself, and they can reduce contaminants by up to 80% or more. The two that we're going to focus on today are Magnolia's SteriPath and Curin. I believe the latest one is called a Curin Jet. So another audience poll then, what percent of collections are completed using a diversion device at your institution? Okay. Okay, excellent. This will be a good topic then. Looks like the majority are currently not using a diversion device. Okay, to get us started then, for our expert panel, you want to talk about your experiences with the diversion device, which one are you using, and why that particular one over the other?
So I am with all of you. We do not use a diversion device. We draw a waste tube or a diversion blood tube prior to our blood culture bottles. That was kind of our first step in this world to try to save money rather than go the diversion device route. So we do not use a diversion device.
At ThedaCare, we do use a diversion device, and we have pretty good usage. We have over 80% of our blood cultures in most of our hospitals collected on a diversion device. We tried the route of the waste tube first, and because it was more of a lab-driven policy that we were trying to push, we did not get a lot of buy-in with our ED staff, hospital staff to draw blood cultures with those waste tubes, so we did not see a lot of reduction in blood culture contamination because of that. And it was actually our ED manager at one of our larger hospitals that pushed for the diversion devices and made it so successful in our institution.
So Dan will go into more detail about what happened at Aspirus, but at Aspirus Wausau Hospital, we do use SteriPath Micro for our diversion devices. In the next year, we will be converting to Curin Jets. We really started using the diversion devices at our facility because our CLABSI rates kept going up. And so our infection prevention and our CNO at the time really needed us to find a better way to try and reduce those. And so we do use diversion devices in our ED off of IV starts. And then our phlebotomy team uses diversion devices for all blood culture collections. That is a goal that they have set. And we have to use it greater than 80% of the time for all of our phlebotomists. We typically right now are running at about a 97% usage for SteriPath devices with our phlebotomy team. Our ED team is at about between 75 and 80%, and overall our hospital uses diversion devices over 80% of the time. We have seen our blood culture contamination rates go down with these diversion devices, so even though there is a cost to using this device, we have seen a reduction in our CLABSI rates and then also a reduction in our contamination rates. I can tell you when we started this project, our CLABSIs, we had about 10 CLABSIs for that year, and as of this year so far, we have only had one. So we have seen a really huge reduction, which does help the patient outcomes and also financially speaking for those patients.
Can you tell them what CLABSI means?
Oh, yeah. Sorry, CLABSI is, oh, did you have a question? So central line acquired bacterial infection or bloodstream infection, so.
Okay, thank you.
Oh, do you have a question?
Okay, yeah.
He's coming.
Actually, want to share, we had a little different experience using diversion. We did about a 9-month trial on it. We're small, so obviously statistically it's hard when you draw less than 100 a month. But we actually found, we used the Cure and Jet in our ER. When in our study, we actually found that labs rates went up using the devices. They were a little more clunkier than the other device, than just using our straight butterflies with proper techniques. So we actually went up about 2% in rate during that 9 months through the ER or through the lab, but our ER actually dropped almost 3 to 4%, which it actually came from the collection techniques. We watched from ER and how they were drawing off catheters, giving that device was a little easier to manipulate, and there was way too much direct drawing from the catheter going on. So, we think that improved the collection technique. So right now we actually moved, the lab is just going off straight cleaning, and the ER continues to use the diversion device.
Another question over here.
I have a question. You had some really good data on utilization. How do you track that?
So we track it using Epic Beaker reporting. We have questions that our collectors have to answer in Epic Beaker when they do the collection. So it's site, volume, and then device.
Thank you.
And so we're able to collect a report off of that in Epic.
We have a question built that they have to answer in there, and it is directly interfaced into our data collection system. We use Power BI, so that question is interfaced into there. So I pull that on a monthly basis and can look and see by department, by hospital, what their usage rates are.
Thank you. Just one follow-up. Are those hard stop questions at collection?
Ours is.
Ours are not, but when they are received in the lab, then we do have to put in, so then we typically will have to call the collector. So they're not a hard stop at the collection, but they're a hard stop to receive for us.
Can you put in perspective for us just what that reduction in blood culture contamination looked like when you implemented that device diversion?
Yeah, Dan's gonna have that in his future slides, so I'll let him talk about it.
Yes, great questions and great segue into the next part of our presentation here. So I'm going to take you along on a predominantly Aspirus journey here for the last 5 years. For context, those of you who are not familiar with the Aspirus system, we're a 19 hospital system in Wisconsin, Michigan, and Minnesota, diverse in size and scope, from critical access facilities to tertiary care. We collect about 50,000 blood cultures per year. So we have a significant amount of experience with this topic. At the time that we started trialing diversion devices, Wausau Hospital was already using best practice techniques for hand hygiene, selection, and preparation. As you'll see, we had a relatively low rate to start with. We were slightly variable in a direct to transfer technique into the bottle. No diversion devices at that time, and we had a mix of RNs and phlebotomy collecting. So our baseline at that time for all collectors was 2% contamination, laboratory 1.4%, and our ER collections at 3.2%. And just to orient you, industry best practice at that time was less than 3%. So we were already doing pretty well. We implemented a diversion device trial with our ED first. That was the area that had the highest rate in 2021. As a result of that trial, all collectors dropped about 0.5%. For laboratory collections, there was no change, and ED collections, 1.1% reduction. So I think Kyle maybe was talking a little bit about this earlier. By the end, a year later, we adopted the diversion devices across all collections at the Wausau Hospital location, and by the end of the year, had it rolled out system-wide. An important factor in this project was a change to our contamination rate goal. So we changed from that 3% metric to 1%. Basically, it had been shown in numerous literature that 1% or less was possible. So we made ourselves a stretch goal to hold us accountable and move toward that. So in 2023, our improvement rate actually leveled out. A utilization goal of greater than 80% was established, like Jessica talked about. Our lab utilization of the diversion device at that time, so about a year in, was only 53%. That moved then from 53 to 85%, and you can see the contamination rate dropped incrementally from 1.3 to 1.08%. In 2024 then, our rates were looking good overall, and you can see on the right the diversion device utilization of 88, 96, and 75%, and those correlate nicely with the contamination rates on the left. Okay, so last year, all collectors, we achieved a 1.05%, high utilization, about 90%, lab leading the way with a 0.991% contamination and a 97% utilization rate. ED collectors also decreasing from their baseline at 1.74% with only a 75%. So take note of the lab collectors there at 0.91 with almost entire use of the diversion device. I'll show some data in a moment. So just a graphical representation of what we went through here. You can see on the left where we started, the laboratory rate in green, and that 2025 data I asked you to earmark. You can see a slight increase even though we had an increase in utilization. All right, I think this is a powerful representation to orient you here. So the bars, the vertical bars, are the utilization of the diversion device, and you can see the contamination rate declining as that rate increases, except for the slight increase in the last 2 years. You see a little bit in the lab data from 0.8 to 0.91. So of course we wanted to know what that might be attributed to. And I'll talk about that in a moment. I'll introduce some data from ThedaCare. Also very powerful and maybe shows one step back from where the Aspirus data started. I don't know if, oh yeah. Okay, so you can see a relatively high contamination rate in their ED collections at the beginning of their project. A massive decrease in about September, and that really had to do with practice standardization. So controlling the best practices that we talked about earlier. And following that massive decline, that's when they actually implemented their diversion devices. So the decreases after that are likely attributed to those diversion devices. See some great months in here with 0%, and looks like they're riding nicely on both sides of their 1% goal. So why don't those rates perfectly correlate over time? So Jessica is the expert for Aspirus. We talked through this last week, and she performed some direct observations of the collectors. And even a few years into the project, can see opportunities for practice improvements. They're doing that each time there's a fallout. So with each contaminant, there's a one-on-one review of the collector and technique. The other thing that she pointed out was turnover of staff in the phlebotomy area requires continuous training. So phlebotomy in many institutions has a little bit higher turnover rate, so it's not a set it and forget it kind of operation. It requires continuous training. And then there has been some periodic influence of agency or traveling staff as collectors. Okay, so we're talking about 1 or 2, maybe 3% reductions. Why do those small reductions matter? For us, it's really decreasing harm to patients. So as our colleagues talked about earlier today, increased length of stay, unnecessary treatment, and antimicrobial resistance can occur when spending time working up these contaminants. Also leads to increased costs for patients and the institutions. So just some general quantification here. Increased patient billing in the thousands or tens of thousands of dollars per episode. Lab time and effort is protocol dependent, depending on what a workup looks like in your institution, but probably hundreds to $1,000 there. And then all the associated costs with pharmacy, medical staff, nursing, environmental services in the thousands to tens of thousands of dollars per episode. And then one maybe that not all the laboratorians are thinking about, but the hospital-acquired conditions that some of you have talked about today, including CLABSI, can lead to a 1% reduction in Medicare reimbursement for your organization. So if you think of all of the dollars that are paid by Medicare for a year or time period, 1% reduction in those payments can be significant. So for us, for an organization our size, this is in the multi-million dollars of opportunity, just with small reductions. Okay, so what else does it take to decrease and maintain contamination rates? Continuous monitoring and improvement, and we'll have our panel experts talk about this a little bit further. But for Wausau Hospital, it was monitoring contamination rates and utilization, education and competency to support the collectors, setting stretch goals and having high expectations for the rates that we can achieve, and sharing results with staff to reinforce. So I'll turn it over to our experts for a little bit to talk about these aspects at each.
So at Aspirus, like Dan said, so I pull a monthly report for blood culture contamination rates and our SteriPath usage. And then whatever phlebotomists do have a contamination, we do direct observation. So our supervisor will go out with that phlebotomist and do a direct observation to make sure that they are performing collections correctly. So if they have 2 contaminants in a month or 2 consecutive months with contaminants, they get a direct observation. I will say that just recently we have seen an increase in our contamination rates, so now any phlebotomist with a contaminant is getting a direct observation. We have a very high expectation of our staff at Aspirus Wausau to make sure that they are following protocols. I guess that's just how I am. We do, like Dan said, we provide that education and competency. They do have to be competent to perform this before they even go out. And then, like I said, we have set goals and expectations for our phlebotomy staff. So that goal of greater than 80% utilization rate of a diversion device is on their performance goals, so their annual performance. And then we also have set a goal on their performance that they have to be less than 1% for their contamination rate. It is a very hard goal for them to reach, but we do know that they can do it. And then we do share our results with all of our collectors. So we publicly post in our laboratory department how many draws they did for blood cultures, and then how many contaminants they had that month, and then also how many of them use SteriPath and how often. I was not posting that, but the staff wanted to know. I think they want to keep each other accountable, and so it has helped us keep each other accountable to where they're at. So, yeah. Do they have a microphone? We have a question.
Thank you.
So I'm Haley from Door County. I didn't introduce myself the first time, but so all these kind of bullet points we're going through, do you maintain that with nursing staff as well, or just your lab staff?
So we don't do that with nursing staff. I do share results with the nursing managers and directors for each of their collectors and their departments, and then it's really up to them to decide how they want to follow up. I do know that our ED manager does follow up with her staff on a regular basis because she takes this very seriously as well. We have great engagement with our ED leadership team, which is really beneficial to us at Aspirus Wausau. And so they are constantly looking at their contamination rates also. And I work very closely with the ED manager and director to help them keep their rates low. So when they start to creep up, that director and manager are reaching out and asking me, like, what can they do? What's going on? Those kind of things. So
That's awesome. You have that engagement. I'm specifically looking at competency. So like we do in the lab, I have a competency I send out. Do you know, does your facility have that for nursing staff, like the ED director or supervisor?
they don't.
Okay.
Yeah, unfortunately, they do not.
Okay, thank you.
I can kind of speak to that with ThedaCare because we did have such engagement from our ED manager, and she kind of laid out what they do for that. So for the ED staff, and it really took them initiating this. This wasn't lab driven at all. This came directly from them. But they do, if they have 2 or more contaminants in 1 month or 2 consecutive months with a contamination, they have to do an observed 3 draws and completely go through their competency program before they're allowed to draw blood cultures again in the ED, which is, I think it's great. It holds their team accountable to one another. Nobody wants to inconvenience another team member when they're unable to finish out their duties with a certain patient. And she said that that's been one of the biggest things that has driven change in their ED. And the data that Dan showed from ThedaCare was all from just the ED draws. So it's been very effective, and it's been able to keep them their rates low for 2 years.
So my story's a little bit different than theirs. We have a very good working relationship with our ED in many ways, but I may not be the only facility in the room who has some pushback from their ED in collecting lab samples. So I have a colleague in the room who will probably smile and nod her head. So it has come up multiple times, like this is lab's job to draw blood samples. Like nursing has a lot to do in a small critical access hospital. Like if you keep giving us more directions or things to draw blood, then you should just do it yourself. So we kind of walk a fine line of a dance as to maybe what I can encourage them to do or ask them to do without breaking that, because we don't want to draw all of the blood cultures. Like if the patient's getting an IV, it's very nice for the patient to kind of save an extra poke. So we draw a waste tube for both the ER collectors as well as the lab collectors. For annual competencies, we use a program called Care Learning. It's online-based modules, right, for safety, fire, all of the above. And so for the ED nursing staff, they have a Care Learning module on how to collect samples off of an IV, which includes blood cultures. So like every year they're getting those visual reminders of like you're drawing this, serum separator tube before you draw or whatever, plain serum tube before you draw your blood cultures. Here's how long to clean the site. So I can't say there's a competency necessarily, but there is a training module that they have to complete with acknowledgement that it's performed. We are similar to Kyle at Stoughton. We draw about maybe 130 blood cultures a month, so our numbers are also small. So 1 contaminant a month is our goal. Our goal is 1%. So I monitor my rates more over time rather than month to month, just because those numbers can jump so much with an N of 100. So we do average a 1% contamination rate with those waste tubes as our diversion device. But I think the benefit for us is that we have less staff, right? We're 1 hospital, 1 ED staff, 1 lab staff. And so like training 40 ER nurses is much easier than training 500 ED nurses. And then I don't know what else was on there. Oh, sharing results. So I do have one of my techs, one of my micro techs, kind of volunteered to take the project of sharing all of that. So I compile the contamination data monthly. I send it to her. She then shares it with both the lab and the ED, what our total collections were, what the contamination rates are as a group. And then if you were one of the collectors that had a contaminated culture, she sends an email directly to them as well as to me saying, you had a contaminated culture, here's what grew, or here was the date. If you would like retraining or something like that, please reach out and let us know. We do not currently do any observations for repeat. I think my team in the lab would be very receptive to that. And probably love that to bring their own numbers down. I would be kind of hesitant to go to my ER nurses and tell them I have to do an observation. I feel like that would set me back in the work we've been trying to do. But I think it's a fantastic idea if you have the relationship to make it work.
Question in the back.
Hi, Jen from Reedsburg. We are also a critical access hospital, and we actually do not let our ED staff draw blood cultures. Although it would be nice for the patient to get it off the IV, we find that in those IV instances, it's just whether we're there instructing them how to clean or not, it just doesn't go well. We also do not use the diversion devices because it's like $20,000. So as a critical access hospital, that's not going to work. Do you find that your rates are still decreasing using that extra tube that has to be cleaned before drawing?
So we also did a lot more education. So like I went to ER nursing staff meetings and like, let's retrain on proper, I've seen them clean a site for an IV start, right? Which is not quite the same as the recommendations to clean for a blood culture. It's a quick wipe and then maybe repalpate and then touch a chloroprep and use it again. And so I can't tell you whether our reduction was partially the waste tube, partially the education, or a combination of the two. But between those two things, it has worked for us. And because I get those emails every month as well, like I haven't seen, we definitely have more contaminations in the ED than the lab, but it does not tend to be one person all of the time. It is pretty varied. But that is something that I kind of monitor as well. Like, is it the same person all of the time?
It's just that more stat situation where they're not taking the time to clean. And
yeah. I think for us, cleaning was the big piece. And I think the waste tube helped with that because it does help capture that skin plug.
I feel
like what Dan was saying.
Be way worse with an extra tube to clean. But the other question that I had was in wondering if you tried any of these like monitoring and sharing and things like that before going to the diversion devices, if you had any luck there. Because it is possible to reduce your rates without the diversion device.
Yeah, so I don't think we shared as much data as we do now. I've been in this position for about 5 years, so kind of as when I took this position is kind of when shortly after we started this project, they did keep quality metrics for blood culture contamination rates and all that. But I don't think it was widely shared with like all of the collectors or even with like nursing and infection prevention, because I do share it with infection prevention as well. So
yeah, because we see really good response from like techs when they see their name. It's like it's their mission to not get another.
Yeah,
so.
And that's what we really saw with our phlebotomy team when they said, nope, go ahead and post everyone's name out there for everyone to see. Like I said, they're holding each other accountable because no one likes to see their name on the board and have a contaminant and have everyone see that. But they are very proud when they go a couple months with no contaminants and they're like, yeah, look at me. So I think it does help.
Yep. Thank you.
We have another question back.
Hi, Hallie from Hayward at Tamarack Health. I just had a question. If you saw any kind of increase in contamination rates, not mainly due to, I say, of the phlebotomist, but overutilization of the order itself. Because we used to average about 130 blood cultures, and then we got certain providers in, and we were averaging over 300 a month for a critical access hospital, and our contamination rates were probably averaging about 1%, and then once we started that, our contamination rates really increased. So I don't know if that was a correlation or a thought as well with the amount of blood cultures being ordered versus the actual collection.
I have not seen it at my facility, but I do think you should connect with Kyle from Stoughton because I believe he has the exact same problem.
Interesting. I would think they would stay proportional or maybe even get better if you're doing more of it. So I think it depends on who your collectors are.
Yeah, so we at Aspirus Wausau Hospital, we average probably 1,000 blood culture collections a month, which is a lot. But we're able to hold at about that 1%, less than 1 for just our lab. So We also changed our orders in Epic, so we now have two blood culture orders. One is blood culture venous and then blood culture line, because we were seeing providers just ordering a blood culture and then nurses would just draw off the line. And we just, and as everyone knows, you really shouldn't be doing that. They should be peripheral draws. And so that's why we made two orders, so that way we would have more of the venous draws instead of the line draws.
Yeah, I
Hi.
think the contamination rate goes up at least 2 or 3-fold when you start introducing lines.
Hi, Eva from ProHealth at Waukesha again. I'm curious about the documentation that you do for the direct observation. With all the CAP expectations now and Joint Commission, is that document discoverable?
It is discoverable. So we have a checklist, just like we would use for a new hire, basically, and then we keep that in their personnel file. But we mark on there why we're doing it. So it's marked on there, the reason why, and then the date. So.
All right, great discussion. Thank you. Okay, so an audience question then. Which groups monitor and review contamination rates at your facility? Okay, so it looks like predominantly lab, and then next would be lab plus nursing and quality. It's good to see that no groups. All right. Okay, another question then for the audience. What type of collector feedback do you find most effective? So continuing on the discussion that you guys are having about real-time feedback for collectors. Okay, looks like more than I would expect are the more daring group that wants wants to see their direct feedback by collector and shared with the whole group. I know I was part of the discussion within our laboratory about broadcasting performance data to a team, and like Jessica said, it was really her team that asked for it. That made that happen. So I think that's been very effective. Okay, we already talked through this panel discussion about contamination rates, monitoring, and frequency. In general, some of the challenges that we experienced was buy-in from leadership outside of the laboratory. This particular project was initiated within the lab, so we had good buy-in from laboratory leaders in our facility and across our system. We were also lucky enough to have very engaged ER nursing leaders and nurse executives at our institution that help drive this performance. Standard best practice for collection, I think, is one of the most important aspects, and Megan's data, I think, really pointed it out very clearly. Massive reduction in contamination rate when they took on the standardization and best practice for collections. Adoption of devices by collectors. If you remember, the Aspirus data after over a year, was only at 53% utilization. It was an expectation that they were used for every draw. But until we monitored that and made a goal of 80%, we didn't see as big of reductions really until we achieved that 80% threshold. Standardization to a single vendor for diversion device has been a challenge and really an ongoing challenge for Jessica. As we rolled this out system-wide to all those different locations, she said that she started with Magnolia Steripath. And I think during that time, Kieran became a more realistic competitor. So actually, at this point, the system made a decision. So Wausau Hospital was the first location to roll it out, and now her team will be making a system-wide change to the other device based on feedback from the whole system. So her group started it. As this other device was introduced, it became a more favorable device for collectors. So the originating group is now having to go back and switch to the other device. Of course, the upfront cost for the diversion device, I heard that be talked about. So they are costly in the $15 to $20 per collection range. But if you remember the opportunities to reduce harm to patients, we felt like that was well worth it alone. And then if you offset that by the other institutional savings and waste that comes with working up contaminants, it offsets and actually is a positive margin. And then just ongoing cost for device and training. So continuous training, retraining, competency, all has to be factored in. Okay, so for our panel, talk about how engaging stakeholders was, how you went about that, and what were the key takeaways.
So I think for Aspirus, it was, as Dan said, it was really easy for us to engage our stakeholders. Like I had said earlier, our CLABC rates were high, our contamination rates were high, and infection prevention really wanted us to take a look. And at the time, our CNO was a big proponent of looking at ways to reduce. And so our CNO at the time really helped drive that nursing executive leadership team to get everyone on board. And then I have always worked closely with our ED leadership team since I've been there, and really just developed a good working relationship with them and was easy to engage. And I think they also realized that it does start with that quality collection. You know, every outcome that a lab result puts out is really based on the collection that's done right at the beginning. And so I think our nursing teams at Aspirus do realize that, and so they do want quality samples. So it was, I will say, I know we're maybe out of the norm, but it was really easy to engage our nursing leadership team to help get this on board.
And our journey with this has not been as easy, and we still struggle, especially with some of our areas that have higher turnover. Critical access hospitals have been a little bit slower to adapt some of the processes, and we can't control a lot of times what happens with our nursing partners, but we've always communicated our contamination rates, what staff members are contaminating blood cultures, and leaving it up to the discretion of those managers to follow up. But within the laboratory, what we can control, we talk about these at all of our infection prevention meetings. We have infection prevention meetings by regions in the ThedaCare system. So we do talk about it at every meeting quarterly, and then within the laboratory, we have scorecard meetings, and we talk about blood culture contamination. It's one of our driving metrics for the laboratory that we, if we get 3 months in a row with, as a system laboratory, over a 2% contamination rate, we have to put countermeasures in place about what we're going to do to correct those, and that's been we've been able to be successful in the laboratory for that, especially with some of our critical access hospitals where usage wasn't as high.
I feel like I talked a little bit about engagement for us. I think the struggle is diversion devices. I don't feel like are the answer alone, right? Unless you can get buy-in from the staff using them, they're not going to fix your problems. You can put them in your ED, but if they're not going to use them properly or still clean or whatever, it's still not going to fix things. So, in my opinion, I felt like I need to start building those stakeholders and building that desire to keep going down a little bit at a time, because throwing a device at maybe staff who don't care a whole lot about the result I don't think is going to fix anything on its own. So I think you need to build the engagement from the user before you try to bring extra technology in to help.
Yeah, well said. Thank you. Okay, sort of an aside question for the audience. Do you notice any trends related to collection volume? Trends in terms of contamination?
Dan, I will say I'm kind of afraid to admit it out loud, but I can't answer that question because we're probably one of the few who don't actually track or monitor. Like, collectors know that you're supposed to fill the bottle optimally, but we do not document or measure the volume anywhere, so I would never be able to tell.
All right, thank you for that. Okay, so it looks like just a slight majority here, no significant trend in terms of volume. This question or speculation tends to come up with collections of low volume samples. I often hear it speculated that low volume collections can be due to difficult collections, maybe a little bit more manipulation. But I think, at least in my experience from the micro lab, with proper collection technique, I don't see a strong correlation in increased contamination due to low volume collections. All right, so Heather led us off with the panel discussion. Thank you for stepping out and saying that. Jessica and Megan, do you want to talk about trends related to volume and how tightly you monitor that?
We do monitor volume, and it's a separate report versus the contamination report. We don't correlate the two of those reports because once those, we can get the data now with our Virtuo instrument of what those volumes were. We would retroactively look, but it's a lot of extra manual reporting. A lot of these reports are already really manual, so we don't correlate volumes versus contaminations.
So we also pull blood culture volume reports. Our technical specialist pulls a report from our blood culture analyzer for me on a monthly basis. And ideally, you know, we want 8 to 10 mLs per bottle. So we do share that data with our collectors in the lab as well, along with their contamination rates. I don't see a significant correlation. I will tell you that typically if I do some deep diving into these contaminants, I do notice that it was probably where they put, it was a Peas bottle, they drew it from a hand or a wrist. And so more than likely when you go back and talk to these collectors, it was a difficult draw. I repalpated. I probably didn't re-clean the site. I just drew because I saw the vein then. So I don't think it's volume. I think it is really based on it's a difficult draw. They probably did not perform the collection the way they should have because they repalpated.
Okay, thank you. Anything different or significant from the audience on this one?
Hi, I'm Laura. I'm from the Zablocki VA Medical Center in Milwaukee. One of you mentioned that the Virtuo was your platform that you utilized for blood cultures, and you tracked fill volumes on that instrument. We found that we had very inaccurate readings from the instrument, and initially we did report fill volumes, but we had to stop because they did not match up with what we had. Things were being over or underreported. And it might have had to deal a little bit with how the bottles themselves were labeled, but just kind of curious if that was something that you ran into issues with as well, or if anyone else here had the same issue, or if it was more just facility dependent for us.
Yes, I've noticed that there's been blood culture bottles that there's clearly blood in them, and it's reporting out that there's 0 mLs in it.
Yeah,
but
very
it was
unpleasant.
significantly better than what we were doing before. We were pulling, the bottles before we were putting them into the Bacti alert. And we were looking at the fill volumes on each one of those, and the staff that were doing that would do a smattering of them. We would do it once a month, so there was hardly any blood culture bottles that were actually being recorded on that. So when I can go back and I report out averages when I do that, so I'm looking at the volumes, I give them like a 2 milliliter leeway on each end of the volume requirement, so it's like it doesn't hit the report until it's less than 8 or if it's more than 12. And we just report out per site what the percentage is for that reason, and it was significantly better than what we were putting out before.
Just to follow up with that, for the ones that did measure as 0 ml, obviously we know that that isn't really the most possible. Would you discard that data, or would you somehow manually read those ones that were the exception there?
I've tried to go back in and like manually read them, and you really can't tell from the photograph that it's taking, so most of the time I throw them out.
That's completely understandable. Thank you.
Does anyone in the room have the ability to get this information, whether it's contamination rates or short fills, more frequently than monthly? Because I think getting that feedback to the collector sooner than 6 weeks after their draw might be helpful. And our quality team has asked me to do that. I don't know how to do that.
So I can tell you, I do look at, not volumes, but I do look at blood culture contamination rates on a weekly basis as well. I had a EPIC beaker report built based off the questions that we do. And so I look at those weeklies because it is nice to do more of a real-time follow-up with staff now, we notice. Because I'm sure, as you all know, if you follow up with staff after like a month later, they're like, I don't remember that draw. I drew 50 people in just the last week. So yeah, I did have a report built so that I could do weekly follow-up.
We have similar, we use Beaker. My reports are built in reporting workbench, so I have the ability to generate them on the fly. A lot of my blood cultures, especially during our monitoring periods of our study, I would run weekly, so I can get more real-time feedback. Again, the other option I have, because we're small, is we actually keep a log of our gram stains, so I can just look at that log and look for any blood culture, positive blood cultures, because we average 3, 4 a month, so it's a lot easier being small that I can use that log to find anything positive and then reference it sooner.
I'm Kaylee. I'm from Amplify Health in Bellin. We do more like tech-based keeping track of contaminants. We more than 75% are nurse-drawn cultures, so we don't really have a lot of techs doing that. But for us, when the bench tech realizes we have a contaminant like a coagulating staph or whatever, we actually do a secure chat in Epic and just let the nursing, whoever the lead is for whatever floor or ED, we just let them know, and then they'll follow up with their staff more real time, versus waiting for monthly reports.
I'm Haley again from Door County. We just went live with Beaker, and one good function, if you have Beaker or any of you, you can actually have it as a follow-up list. So if you can come up with a list of organisms that are considered contaminants, it will flow to that list. I check it daily. That's real time. It tells you everything about it. So it tells you if you record volume, it tells you volume, organism, and the collector right away, right up front. So it's very easy, and you can actually put in like a note for that task, and then access that data at the end of the month or weekly if you wanted to look at all of it together. So that's a function you could try to utilize. Again, a daily one and more real time, which I have already found very beneficial in the short month we've been live with that. So that's a really good way as well.
Okay, then to summarize, so key takeaways, engage and align with key stakeholders, focus your effort on the highest volume collectors, likely going to be lab and ER for sure. Technique standardization, very important, highlighted by Megan's data. Continuous monitoring and feedback. I think a couple good examples from the panel and from the room about that. Unified goals and expectations across the laboratory and organization in general. Use contemporary best practices for collection. I heard a number of audience members talk about a 1% contamination rate. I think that really speaks to the overall trend that we're seeing in the industry. Less than 1% is definitely achievable with sustained effort. Timely observation and retraining for fallouts we just talked through. And then training and competency really to match your turnover rate. Important that it's not a set it and forget it kind of operation. Requires continuous training and competency. So any follow-up questions?
So we're right on time right now. We're about 5 minutes ahead of schedule. So we do have time for a question or two before lunch.
Kind of a question for the panel, because I was in your rates, in your, what do you define as a contaminant, and specifically that 1 of 4 of a pathogenic organism, or say you have an E. coli in 1 of 4 bottles, are you including that in when you look at your contamination rates?
So it's not super straightforward, and it's certainly not a black and white process like everything in micro. It's in the gray area. But usually if it's something that it would be a normal skin flora, so like our coag negative staphs, diphtheroids, some of the alpha hemolytic streps. If it's only in 1 bottle, or if it's only in 1 set, if there are 2 sets drawn, we consider that a contaminant. But there are certain organisms that we've ruled out. So if it's a gram-negative rod that's only in 1 bottle of 4 bottles drawn, we would not call that a contaminant.
Yeah, for us, we use the NHSN Common Commensal list. It's about 5,000 organisms that are considered to be normal skin flora.
We're the same. Yeah, I mean, Micrococcus, Bacillus, those are on my list too, but otherwise all the same things that Megan said. Something like a gram-negative rod in 1 bottle out of 4, to me, is still a pathogen. I would not consider that a contaminant when I'm doing my reports.
Dan?
Yep.
Hi. So were you citing data of like $1,000 and $10,000 for workup of a contaminated blood culture? Were those the data you cited in your presentation? Did I get those right? Way back, like million slides ago.
Some of it, do you mean cited in publication? Is that what you're?
Sure.
Oh.
Yeah.
Some of it I took from our own organization, and some from the literature that I have cited here.
Okay. So I guess this is kind of for the pharmacists in the crowd. What is the general cost of starting Vanco? Like on a contaminated blood, like gram-positive coccidin clusters, it goes through all the molecular testing, turns out to be a non-MEC-A, turns out to be maybe a non-Staph aureus, it's coag-negative Staph. What would a general Vanco workup be for cost, for like 3 days or something like that? What's that? Well, yeah, so what if you have to stay on the Vanco for 3 days in a contaminated blood culture?
I normally don't have to review the cost of drugs, so I'm not sure. I mean, I could go on Lexicomp shortly and tell you over lunch if you want. But
I'm just curious, and I'm kind of playing the Debbie Downer here a little bit. If we're majorly kicking butt on lowering contamination rates, if we're lowering contamination rates like crazy, and great job to the 1%, that's awesome. Is there ever a point where a bean counter is going to come back to a person and says, are we spending too much on diversion devices per year when you're having a 1% contamination rate? I'm doing math on a piece of paper. I know the math is wrong, but diversion devices seem to be giving you a great yield on lowering contamination from 3% to 1%. But is there ever a point where the accounting person is going to tap you on the shoulder and say, hey, your 1% is great, but you're spending too much to get there on a diversion device? Has that thought ever been encountered from a bean counter or approached in a discussion? I'm just curious.
Yeah, for sure. I think, at least for our organization, the desire to do less harm, to do no harm for patients, goes a long way. We're still in the black as far as cost, but not by a lot. The diversion devices are very costly, but again, when you consider all of the downstream costs and harm to the patient, even that small reduction is worth it for us.
So I'll just add to that tap, Eric. As the bean counter, by the way, Nate Ledabor, Prairie at ThedaCare South Region. As the bean counter, 100%, I'm going to want to see a business plan attached to doing that. I'm going to want to see outcome data attached to that. And if I don't see that, we're going to say goodbye to that diversion device fairly quickly. And they are realistically extremely expensive.
All right.